Good morning. My name is Nikki Keefe. I'm from the University of North Carolina, and I'm representing the Voices newsletter for the Vein and Lymphatic University. I have with me today Dr. Bill Majdalany, who's the Division Chief of Interventional Radiology at the University of Vermont. So welcome, Bill.
Thanks, Nikki. It's great to be here.
So recently you were talking about how you use pressure measurement in lymphatic disease to gauge when to treat different things. And I found that fascinating. So I was hoping you could tell me more about it.
Yeah, absolutely. I think this is something, and I think that fits in the broader scheme of lymphatics that we still are developing an understanding of. The lymphatics ultimately drain so many different compartments of the body, whether it's the liver, the mesentery, or the periphery. And necessarily, disease processes in those different compartments can affect how lymphatic flow proceeds. And when we measure pressures, we're used to measuring pressures in the portal system or in the heart or in the lungs, etc. It stands to reason that this other component of the circulatory system, the lymphatics, also will have associated pressure measurements and or gradients that we may potentially intervene on.
So, we have a good idea of what is considered a reasonable pressure gradient in the arterial system and even in the venous system. So, where are you even getting these numbers from of when you're deciding to choose when to treat something?
That is a great question. Part of it is a trial by error, I suppose. I think we all know when something is abnormal, when it's really elevated. I think the challenge with lymphatics is we don't know what the full spectrum of normal is. The structure of lymphatic vessels or the number of valves and how competent the valves are, et cetera, is something that is still in this blue water of discovery of things that we need to understand better. But through the liver, the lymphatics, uh, portal pressures can be transmitted to the lymphatics. And we know that if you intervene on the lymphatics, you can decrease portal gradients. There's a prospective trial published not too long ago in JVIR out of France, where in patients who couldn't have TIPS or liver transplants for different reasons, underwent lymphatic stenting of the terminal thoracic duct, and it decreased their ascites and necessarily their other pressures. And we also see patients that have thoracic duct blockages and or narrowings where there's a slow or no flow from the thoracic duct into the central venous circulation. And then when you intervene on that, it resolves their symptoms. So there is some degree of a flow discrepancy, an abnormality to the size and or distension or lymphangiectatic experience to some of these lymphatics, which can be resolved by treating it. What the actual numbers are, what they should be, remains to be completely elucidated in the literature. But, I think if we see gradients above 10, I think all of us are generally inclined to intervene on that. But what is normal versus abnormal? Well, we're still figuring that part out.
Have you, just for our readers' knowledge, have you come up with what you think might be an average pressure measurement for the thoracic duct?
I wish I could say that I had. And I've gotten better about measuring it more consistently in patients. But one of the challenges comes down to obviously how often patients are breathing and potentially maybe finding a reproducible way to measure the pressures, potentially when a patient takes a deep breath versus when they exhale, and seeing what the pressure variations are in a respiratory cycle, and maybe using that as an average. So I can't say that I've nailed down how I want to do it. But what I generally do before I intervene is measure it across segments as I pull back, and I watch it go through multiple respiratory cycles, and then I average that, and then I do the same on the other end. For example, at the thoracic duct venous junction, I'll measure it on the venous side, pull back across the valve, and measure it again. And potentially when doing liver interventions, also having right atrial pressures and or portal pressures and understanding the pressure differences pre and post intervention and or doing plasty.
Are you just measuring with a end hole catheter?
Sometimes with an end hole catheter, sometimes with a balloon. It depends on my approach to the thoracic duct access. If I can go retrograde, I will tend to use a balloon, a small sheath, or do an over-the-wire measurement. If I go through a transabdominal approach to access the thoracic duct, then it'll usually be through an end hole catheter.
I imagine that you don't see any sort of waveform with lymphatic pressures.
Not consistently. And again, I think because they're so small and the pressures tend to be on the lower side, um, that gets buried in the overall respiratory cycle. So you're not seeing something with the right atrium transmitting pressure, as you would like in the right atrium where you're seeing a consistent waveform, et cetera, or the portal flow. And I think one of the things that remains incompletely understood is that we know that the central lymphatics have a propulsive forward force from their smooth muscle layer that's different than what you would see in venous circulation, which relies maybe a little bit more on valves and respiratory drive. So I think understanding that physiology is something that we're really still trying to peel those different layers of the onion to figure out how to approach it.
I'm going to expand upon pressure measurements a little bit. I know I didn't forewarn you about this, but um, when you're measuring pressures and you come across a gradient and you want to treat that, noticed that you're stenting. So can you tell us more about lymphatic stenting?
Absolutely. Well, I do sometimes plasty and sometimes stenting. And, if there's something where I need to exclude the circulation and or it's a patient, for example, that was in the ascites cohort where they're in an end stage disease process without an alternative potential treatment, then I think stenting is the way I go. But if it's somebody who is presented with a complaint and may have an alternative treatment, so for example, has a thoracic duct terminal occlusion, what I'll do is I'll treat it really no differently than a thoracic outlet syndrome, where I'll go and I'll plasty serially, make it larger, try to decrease the gradient, get flow going, have them evaluated for potential lymphovenous bypass by one of the surgeons who specializes in that, not necessarily at our medical center, but there are a few medical centers and a few plastic vascular type surgeons that will do that. And if the patient does not want to undergo that, then I'll consider either repeat plasty with serially larger balloons and or stenting. But I, because these cases are still uncommonly seen by the vast majority of us or unrealized, I try not to do something irreversible in the sense of placing a stent. So what I'll typically do is I'll use an 018 platform or 014 platform balloon, and I'll do serioplasty, or I'll use a sniper catheter, for instance, and use it similarly to like a micro Fogarty and pull through, and then use serial balloons in the 2, 3, 4, up to 5 millimeters at least the first time around. See how things go, how the gradient goes. I really want to decrease it by half. That's not scientific; it's just my hunch, and then reevaluate, see how the patient's doing. Generally, once you understand the lymphatic anatomy, subsequent interventions may not require lymphangiography or transabdominal puncture, and you can probably start going retrograde transvenous for those. So at least that's been my experience so far.
When you're talking about serial dilation, how large of a balloon will you get up to?
In the first go around, I'll go up to 4 or 5 millimeters, and I'll go in 1 millimeter increments. So I start with 2, and then 3, 4, and then 5. Either a 2 or 4 centimeter length. And the subsequent, the largest I've gone is up to 8 millimeters in somebody who had very dilated lymphatics, which obviously want to size it to the inflow vessel. Obviously, the outflow vessel is usually not as big a deal because you're talking about something near the brachiocephalic junction, which are fairly sizable. So it really comes down to the lymphatic that you've navigated in, and you really want to make sure that the anatomy of that terminal lymphatic, it may be a single barrel, it may be more than one channel, it may be plexiform, et cetera, that you don't rupture. And if you do, you may have to potentially stent at that point versus finding a different outflow through one of the other channels if there are several competing channels.
And when you do have to place a stent, whether for rupture or failure for plasty, how are you sizing your stents?
So, also a very good question. I generally size it to the inflow vessel in the neighborhood of 4 to 5 millimeters. My uncovered stent that I've been using is usually a silver platform. They're pretty easily delivered on a 5 French, overall 5 French platform. And the stent grafts that I've been using have been Viabonds on an 018 platform as well.
Great. That is such an educational, so much great information on lymphatic disease in an area that so few of us practice at really the height of what we can do in the lymphatic world. So thank you so much for sharing that with us, and I look forward to speaking again soon.
My absolute pleasure. I hopefully I gave you some more answers, and maybe I raised some more questions. And I think as all of us start to see this and notice it more, we'll keep on forging forward.
Thank you.
Thank you.